Okay, this video is called "Is Brain Cancer a Joke?" So, the reason I'm phrasing it that way is because everybody's worried about a brain tumor, about brain cancer. I can tell you, I almost never see brain cancer. It's rare. It's super rare. If you doubled the incidence of brain cancer, it would still be rare. If you tripled it, if you quadrupled it, if you multiplied it by 5, it would still be rare. And the reason I'm going through this is because everybody keeps talking about, do cell phones cause brain cancer? Do cell phones cause brain cancer? And what I'm trying to say is that's the wrong question. The correct question is, do cell phones cause brain damage that make you stupid? That's a key question. And I say this because, I work as a neuroradiologist. It's one of the things that I do. I'm actually, board certified in 3 different specialties, but I do a lot of brain imaging, okay? And I do a lot of study of cognitive decline. I teach other doctors why patients become cognitively declined. And the reason I tell you this is because on a given day, let's say I look at 100 brain CTs and MRIs, about 30% of the patients will be fell and hit head. It'll sometimes say patient on blood thinners, or it'll just say head trauma. Usually it's fell hit head. Sometimes it's a motor vehicle crash, something like that, but usually it's fell hit head. And it's usually old patients who are half confused anyways. Okay, then I'll get about 10 headaches. Sometimes a headache will say rule out subarachnoid hemorrhage. But the point I'm making is TBI, traumatic brain injury, super common. It's also very common to get rule out stroke. Patient will have some vague symptom, rule out stroke. Yeah, of course, occasionally you get a more major stroke with, hemiplegia on one side of the body. But very often it's just something's off, rule out stroke. Okay, and then the most common thing I get is memory loss, cognitive decline, delirium, confusion, acute mental status changes, MCI, mild cognitive impairment, dementia, brain fog. That is super common. And it's so common that a lot of people don't even seek help for it. They go, oh, I'm just getting old, I'm having a senior moment. And what I'm saying is, if you focus on how can I avoid cognitive decline, you will address all the major issues in brain health. And that's why I emphasize that, because if you want to have good cognitive function and be healthy, that's what you focus on. And if you focus on optimizing your brain health, you're going to keep your coronary arteries clean. The brain's a lot more fussy and difficult to please than is the heart. Okay? And I said that plenty of times before. I'm taking you guys beyond clean coronaries. Yeah, Esselstyn is awesome with his keep the coronaries clean, but we're going to go better than that. Okay? I'll see, some dizzy, ataxia, syncope means falling down, that sort of thing. Like I said, rule out stroke's common. I'll get a couple rule out meds, work up for tumor patients. The vast majority of these cases are negative. Yes, of course, brain meds do occur. They're usually a relatively terminal event. Patients, most of the time, don't live very long after that. You can sometimes keep them going for a while with, radiation therapy, for example. That's a whole other topic. Okay, now, so the point I'm saying is, traumatic brain injury, stroke, and cognitive decline, that's a horse. There's an old medical saying, when you hear hoofbeats, think of horses. All day long, tons of patients I see this. And then when I interact with patients for other reasons, let's say I'm doing biopsies, or I'm just talking to patients for other reasons, or I'm talking to the doctors about their families, this is the stuff that's super common all day long. This is what you should worry about. This could happen to anybody. All right. On the other hand, there's diseases like Parkinson's disease, which is obviously an important disease, but it's uncommon. It's like a zebra in terms of its frequency compared to a horse. All right, and then there's really rare diseases like ALS, amyotrophic lateral sclerosis, Lou Gehrig's disease. That is super rare, super rare. I'll see maybe one case a year, okay, and the MRI usually won't tell me anything. There's some rare signs I can see, suggestive of ALS. They're super rare, okay. And then there's things that I think are just sort of nonsense, really, like Alzheimer's disease. And why do I say Alzheimer's disease? Because I know you're going to read elsewhere, oh, Alzheimer's is the most common cause of dementia. I think Alzheimer's is a scam, and I've told you why before. There's no physical finding. There's no historical finding. There's no good imaging finding. Even at autopsy, they can't effectively, conclusively diagnose it, okay? So what I'm trying to say is what usually gets called Alzheimer's dementia, in my opinion, in the vast majority of cases, is the things like I've talked about. Vascular dementia, like the dilatory theory, or my own theory of excitotoxicity-induced dementia, okay? And there's more to it than that. I actually think Paul's no theory of oxidative stress is a contributor to what I would describe as excitotoxic induced neurodegeneration. And by that I mean, when the metabolic rate greatly exceeds the oxygen and glucose delivery. We'll talk about that in other lectures, but I'm going to show you a couple pictures now of what these things look like. But it's important that you think about what really matters. And I can tell you, I've looked at a lot of writers, and I look at the quality of their books. And it's a common thing I'll see that a writer was great when they're about 50 to 60 years old. And then when they're 70, they're sort of lost a step. They're no longer as clever and funny. Okay, and there's exceptions to that. There's some authors writing masterpieces when they're old, like Victor Hugo, for example. All right. But anyways, I call Alzheimer's because I think, it's a convenient way to sell drugs, okay? This is Alzheimer's, take our pill. This is Alzheimer's, take our pill. Versus when you talk about all our theories, you need to have a good theory of disease because it tells you what to do. And when you go through Delatorre's theory or my theory of, neurovascular uncoupling, you know what to do, okay? So, all right, let's look at a couple pictures here of what these things look like on brain MRI and CAT scan. So this is a big subdural hematoma. This would be a chronic subdural hematoma, an old one. This is a more subacute to acute. Acute is usually more dense blood here. This is sort of a mixed low density, higher density blood sedimenting out the heme down in gravity dependent fashion. So this is really, really rare. Okay, I see subdural hematomas, but not that much. If you're working in primarily a trauma center, you'll see more of these where there's a lot of motor vehicle crashes. There's some hospitals, that's what they are, trauma centers, and they're right next to a big highway, okay? But we don't see these that much. Okay, you do see them, and this is a big reason why all these felt-hit heads get imaging. Rule out subdural hematoma. You can take this to the operating room, drain the subdural hematoma, and the patient, you could save their life and they'll have a big cognitive improvement. That's an uncommon event. Okay, yeah, it happens, of course, but it's not common. Okay, here's a small perimesencephalic subarachnoid hemorrhage, and this could be spontaneous, it could be a venous bleed, it could be an aneurysmal bleed, but okay, this is super rare, super, super rare. I'll see one of these every couple of years, all right? Here's an interventricular hemorrhage. This might be from the shunt placement itself for treatment of hydrocephalus. You can also get post-traumatic interventricular hemorrhage. I've seen patients on anticoagulation get spontaneous interventricular hemorrhage. But IVH, it's rare. It's really rare. I see IVH, interventricular hemorrhage, once a year. Okay, so it's not common. All right, now here's the common stuff. Here's a normal brain, okay? This is what's called a flare sequence, flare right here, which is really like a T2 sequence with suppression of CSF signal, cerebral spinal fluid signal. So basically, what you all want to do in all MRI is suppress the background signal and then increase the pathology signal, the disease signal. So this would be a normal brain, normal sized ventricles with no significant periventricular abnormalities. You get a little bit of hyperintensity in the cortical spinal tract, that's normal. Okay, you get a little bit of, of increased signal at the ventricular frontal horn tips, that's normal. Okay, but here is the problem. This is what I see all day long, every day. And this is why you might have heard me say some patients can have 100 strokes. Okay, because there's these little silent strokes. These are also referred to as white matter disease. If you hear somebody say a bunch of white matter abnormalities, this is what they're usually talking about. The vast majority of abnormal signal in the white matter. The white matter means the myelinated axons that travel between the cortex. Cortex means bark, like the bark of a tree. And that's also called the gray matter ribbon that's traced around the periphery of the brain. That's where the neuron cell bodies are. The neuron cell bodies have about 4 times as much blood flow as the white matter. So they're denser on CT. And on an MRI like this, they just have a little bit higher signal intensity than does the white matter. Okay, so what I'm showing you here is all these white spots, they're abnormal. These are a bunch of strokes. These are usually silent strokes. When I say they're silent, I mean that they usually don't cause a neurologic deficit. A neurologic deficit is something like paralysis of the arm or paralysis of the leg, weakness of the arm or the leg that's, noticeable, detectable, significant. Okay, these often are just a person getting slower and stupider as they get older. And these are very, very common, okay? Most Americans over the age of 55 have at least one of these silent strokes, okay? Don't get me wrong, I see lots of clean brains. I see a lot of people who have clean brains into their 80s. But I can also tell you, it's pretty routine to see at least one of these things, and I'll often see hundreds of them in the same patient. And I would think of this as being like Ehrlich's metaphor of popping rivets off an airplane. Okay, eventually the airplane's not going to fly too well. So this is why you want to keep your arteries clean so you don't become stupid. All right. So these would be this would like the way. How would this MRI be described? This would be described as extensive periventricular flare hyperintensities, most likely due to chronic cerebrovascular ischemic disease, meaning due to hypertension, atherosclerosis, and of course diabetes is mixed in there too. And it could be due to the arterial capillary thickening, decrease in oxygen delivery due to hypertension or diabetes. It can also be due to overtreated hypertension, leading to not enough pressure to get the blood up to the upper parts of the brain. Why do you think people have hypertension? To get enough blood to the brain. So you got to be careful about overtreating it as well. Okay, here's your classic acute stroke. This DWI stands for diffusion-weighted imaging, and that's a big improvement in MRI. It really became widespread in its availability about 10 years ago, and it enables you to see a stroke immediately, okay? So a stroke on flare doesn't usually show up until about 6 hours after the event. DWI shows up immediately. ADC is a way you can tell how acute it is. So ADC sequence will stay abnormal for about the first week. DWI stays abnormal at least 2 weeks, quite often stays abnormal for 2 months. Anyways, these are ways to time a stroke. But, you know, strokes, they're not that common, big strokes like that. So I would call that a cortical convexity stroke as compared to those previous periventricular silent strokes. Okay, now here's a big cortical stroke. This is the kind of stroke that patients often die from, and they have cognitive impairment immediately after the stroke. So this would be infarct-related dementia. It's uncommon. Okay, so here's a big stroke. And I'll see these types of strokes occasionally, but they're not that common, okay? And this might be like atrial fibrillation, and they'll toss a clot, an embolus up to the brain and occlude the middle cerebral artery. This is on the right side. It's as if the patient's feet were facing toward you. That's how you can tell right side from left side. So this would be a large right middle cerebral artery stroke, okay? And this looks to me like sort of subacute, acute to subacute. Okay. Maybe a little trace hemorrhage right down there. So anyways, that's a big cortical convexity stroke. So cortex is a gray matter ribbon. Convexity means it's outwardly convex, outwardly round. Okay. So that also would be due to an LVO, a large vessel occlusion of the middle cerebral artery. All right, but I can tell you this. This picture, this CAT scan right here is hundreds of times more common than this. I see this all day long, every day. Usually the patients are over 60 when I see this, but I sometimes see it in young patients. All of this periventricular tissue, it should look like this, okay? Instead, it's markedly low density. That's pathologic. That's due to those silent strokes. So what we saw is the bright white spots on MRI. This is what they look like on CAT scan, low density, fluid. You might call it gliosis, a little bit of edema mixed in with the gliosis, the fibrosis, scar tissue in the brain parenchyma tissue replaced by destroyed tissue, okay, by scarring, okay? So this is a disaster of a brain, and this is a very common appearance for brains in Americans. We sometimes will jokingly call this cheeseburger brain. They plug up all their arteries, and so all their association fibers are trashed, okay? This person is going to be cognitively very slow, if not demented. Okay, and then here's what I want to show you. This is what I see most commonly. Very little, if any, periventricular low density. This is a CAT scan. You can tell because the skull is very bright, from the bone density. CAT scans are all based on density. MRI is all based on signal. Okay, so anyways, the point I'm making is the majority of demented patients I see, they look like this. The brain is shrunken. You have an increase in the amount of cerebral spinal fluid, this dark stuff around the convexity of the brain. Okay, and the brain is sort of sitting in this fluid. You look at the young brain, you show me the brain of a 20-year-old, this brain parenchyma is going to be out here just about touching the skull all over. You'll barely be able to see any cerebral spinal fluid. It'll look like it is down here, a tiny bit of cerebral spinal fluid, a tiny bit of cerebral spinal fluid. You get these old atrophic brains, American cheeseburger brains, due to chronic apoptosis, due to neurovascular uncoupling, and this is what they look like. And I see this all day long, every day. I'll see this from across the room, okay? This is so common. Some people would even call this normal brain for an older person. I've seen that. I've seen patients with a bunch of silent strokes, and their doctors will say that, oh, that's just normal aging. No, it's not. Okay. I also had an interesting experience. One of my neuroradiology friends, she did her residency in a hospital located in a Chinatown part of a big city. Okay, and it was actually Chinatown in Chicago. And she told me that they were amazed at how good all these old Chinese people, their brains looked. They had very little atrophy. You know, they're eating the rice diet. The old timers were, you know, probably came with their families and they're still eating the old rice diets. And they had relatively little brain atrophy, you know. People get head CTs for all kinds of reasons. Like I said, fell hit head, headache, etc. Okay, here's typical hypertensive type stuff. Usually you don't see this many, but we do see these every day. Little hypertensive bleeds centrally is classic location for hypertension. Peripheral bleeds, they sometimes say that's something else called cerebral amyloid angiopathy, which is sort of officially associated with Alzheimer's, but Alzheimer's is kind of bogus, as we spoke about before. And I think hypertension is the main underlying cause here, as well as there's secondary issues. There's beta amyloid within the wall of the vessel. We don't need to get into all the details, but all I can tell you is the same patients that got these hypertensive hemorrhages, they also tend to have hypertensive retinal hemorrhages quite often. And it's a spectrum. It's not discrete diseases. It's a spectrum, and there's a tremendous amount of overlap. Here's a large focal hemorrhage right here in the basal ganglia, and that is a classic appearance of a hypertensive. These things are rare. How many hypertensive hemorrhages do I see? I'll see about 2 a year. Big ones like this. I'll see these every day. But I only see about 2 big basal ganglia hypertensive hemorrhages a year, maybe 3. Okay, the little tiny bright spots right here, those are just calcifications in the basal ganglia, globus pallidi. And here's a calcification in the pineal gland. I see pineal calcifications all the time. And that might be because of F- in the water. It might just happen anyways. But basal ganglia calcifications, we consider all this stuff normal because it's so common. But I don't really think calcifications in the basal ganglia globus pallidi is normal. I think it's probably due to atherosclerosis disease destroying that tissue. Normal tissue is not calcified. Okay. Average American doesn't age well. Okay, now here's what looks like a brain tumor. Either a glioblastoma multiforme, often abbreviated GBM, or a MET. METs are much more common than primary brain tumors. Okay, GBM, yes, it's a very serious disease. It's a very sad disease. The patients, often don't do very well. They can surgerize this thing, but how well are you going to do if they take out your right frontal lobe, okay? They can radiate it, and that can, slow it down for a while. They give chemotherapy. All of that can keep the patient, alive a bit longer. There's some reason to believe that nutrition might help. There's a book called Stop Feeding Your Cancer by a Irish doctor named Kelly that was pretty good, and he talked about some GBM patients doing well with dietary approaches, but I don't know much about it. People talk about keto, but keto sounds kind of stupid to me. That Seyfried guy works on it. But all I'm trying to tell you is brain cancer is rare. I hardly ever see it. So don't think about that, because you'll just be confused and you won't know what to do. But if you think about the stuff I've been telling you about, the dilatory theory of like mouse equivalents, of underperfusion of the brain, chronic cerebral hypoperfusion, and you think about my theory of neurovascular uncoupling, and you follow these lectures I've been talking about the effects of EMF and cell phones and all this stuff, then you know what to do. Avoid all that stuff. I've sort of given you guys over 60 different things that cause brain damage, and each one, seems relatively minor by itself, but they all add up. And the good news is almost all of them are avoidable. So anyways, I just wanted to make this lecture to give a relative sense of how common the different diseases are, and by avoiding the common ones, you minimize your risk of all of them, including your risk of Parkinson's and ALS and brain tumor.